So here in Hampshire Hospitals, we have been working together since 2008, 2009. Colleagues like Dr. Martin Kim, other colleagues in acute medical division, as well as intensivist, emergency departments, and in fact all other departments. And we have working in this unique way, and that's based on professional trust, professional relationship, taking away our individualism, but more concentrating on patient's experience and patient's pathway. The work started initially by introducing novel markers such as procalcitonin, which is a marker more sensitive, more specific for bacterial infection, to see how we could improve our antibiotic stewardship, especially avoiding unnecessary antibiotic use when patients do not need it. And it was a collaborative approach. We had a meeting with acute medical physicians, with our intensivist colleagues, with our colleagues from ED. See how could we use this test in those cases when we are not sure. There's a term called just-in-case antibiotics. We, as clinicians, we cannot be sure all the time, 100% of the time. And there are times when we see patients, they have some inflammatory response. We don't know if this is due to an inflammation or whether due to an infection. And to avoid those just-in-case antibiotics, we have introduced this procalcitonin test. And since then, we have noticed reduction in our antimicrobial. And in some cases, when we have looked back, 1 out of 5 or 1 out of 6 courses of antibiotics could be unnecessary and could be safely stopped or not be given at all to patients without causing harm to patients, without affecting mortality. The way we work here is the clinical microbiologists have daily ward rounds to intensive care unit, to medical admission units, and to the other areas in the hospital. But the daily ward round include a collaborative board round with acute medical physicians to discuss patients and their infection to have the most impact on the antibiotic stewardship as well as the patient pathway. And this uniqueness of our work is not only reducing unnecessary use of antibiotics, which we have demonstrated 17% reduction in unnecessary use of antibiotics, but also its impact on selecting out superbugs, as well as improving cost to the NHS.
So sepsis is infection with badness. It's the sharp end of infection. It doesn't have a diagnostic test yet, but Cordo and colleagues are working really hard to help give us a biomarker that will point us in that direction. All we have pending that is the clinical judgment of our clinicians, coupled with physiological scores. And the new NHS sepsis implementation guidance suggests that a news value of 5, combined with the clinical judgment of a decision maker to determine whether sepsis could be present, gives the diagnosis of suspected sepsis. Because we don't wait for tests with bad infection. We cannot afford to. We can only go on judgment and what we suspect, what we feel may be the cause of the problem. So we use News, which has been updated to News 2 recently, and assesses 6 different physiological parameters with the addition of oxygen as well, and tests for oxygen, blood pressure, heart rate and the like, and can be done everywhere and anywhere in healthcare. It takes about 2 minutes to do, can be communicated within 5 seconds. And when it is communicated and everyone in the pathway knows the level of sickness that they're dealing with, it can save lives. Because we're prepared, we can prioritise, we can plan, and we can have the right people ready to receive a patient who is sick for any reason at all in the right environment. Each one of the scores that one derives from a News 2 can be added up to give you a risk, and that risk predicts whether patients are likely to die or survive, and it predicts their recovery as well. With News 2, it gives us the opportunity to align the pathways for infection with those for deterioration. Because when someone gets ill and they come into an emergency hospital, you simply can't tell what's wrong with them. And to have blinkered pathways that only think about one specific condition misses the whole point and loses people along the way. So by having a combined deterioration pathway, we can actually assess the needs of every single sick patient that comes in and treat them appropriately with the right level of seniority and the right level of urgency based on their mortality risk. And the exciting opportunity is how we combine infection, antimicrobial stewardship, and all-cause general deterioration into the whole package that will lead to lives being saved. Years ago, we used to give weeks and weeks of antibiotics just in case. We no longer do that, thanks to the relationship between microbiologists, clinicians, and the advent of point-of-care tests like procalcitonin.
Yeah, and that's excellent because we have stopped giving unnecessary use of antibiotics without causing harm. And what we need to do now is being more innovative and bring in more biomarkers with clinical scorings in order to not only recognize sepsis, antibiotic stewardship, but also triaging and also monitoring patients to see who would deteriorate in a shorter period of time.